Excellent. Okay, so my name is Kate Polson. I'm founder and managing director of Help For You. We are actually a social enterprise, so not specifically a charity, and we've been in the role of health navigators and case managers for just on 10 years. So what I'm here to talk about today is the learnings that we've had over the last 10 years in terms of providing that service and the data that we've collected, and the next step, as we understand it, in this in this landscape of measurement and data and involving a number of organisations in that process, which is about engaging the consumer not only in terms of co-design or engagement, but consumer-led care coordination. So a little bit about us. We've helped navigate over 3,500 people over that time. The key thing is 80% of our activity is resolved on the same day. So if you think of any kind of issue with access to health services, finding out what's happening, ACC, insurance, healthy homes, pretty much anything you can think of in terms of keeping someone healthy and well and safe and confident in their home environment is what we do. And we turn around those cases 80% on the same day and 90% within 24 hours. And the way we do that is the database and the systems and processes that we've developed. In 2009, we started out by running a government-funded Language of Health forum where we engaged a range of stakeholders across health and social services, including patients and family and support people, in understanding the language of health. And obviously what we found was that all the terms and languages were used interchangeably and there was no common understanding of that. From there, we developed a community care data set, which again was supported by government funding, Ministry of Health, and that was taking the 18 national collections that we already had in government and trying to map them to some sort of standard index. We've done work with Plunket and with Nurse Maud over the last 5 or 6 years in terms of supporting their electronic health record initiatives. So established in 2007, case management care coordination, we've got particular expertise in taxonomy, guidelines and pathways. We have a software application that we've developed on Microsoft Dynamics CRM, and that's an activities, events, services and outcomes planner, and it tells patient stories. And we use a taxonomy, which I'm going to talk about briefly, called the Omaha system, which is an international methodology for capturing patient or individual, family and community level information. So in terms of measurement, which is one of the themes of today, our measurement objectives are primarily to document the inputs to care and evaluate the effectiveness of the services. We assume in that there is a plan. So we assume for any individual or family or community that we're dealing with that we actually know what we're planning to do for them. We are looking for at-a-glance visibility of those inputs across the care continuum and everything that entails. Obviously, we want a minimum of duplication and rework, which I think we're all in agreement around, but also it creates an opportunity with good data integrity to look at the costs of the inputs of care, both in terms of what's planned and what we do, and obviously from that we've evolved to wanting to understand what's the difference between what the pathway is, which is the whole population of what's possible, relative to what's the plan for this person in their context, to what did actually happen. So as I mentioned, we have a platform called Aesop. You know, Aesop wrote fables. We think of our software as providing short, succinct patient stories with a moral message, much like a fable, focused on community and home-based support. As I mentioned, we use the Omaha system taxonomy. We map to all the national collections and international coding systems. So on Microsoft, we've been in production since 2011, and we've been a finalist in national and international awards. So I'm going to take a moment to talk about Omaha system, which is the taxonomy of choice. So we undertook a process of looking at all of the different methodologies for structuring data for health and social services. We did this through a couple of government grants, but also through extensive international research, including travelling overseas quite a bit. And we found this taxonomy out of the state of Omaha out in Nebraska in the US. It's been around for about 40 years, and it was designed to support home-based services. There's been a lot of work done by ourselves, Plunkett, government agencies, University of Auckland and others, who've identified that it is probably a good fit for New Zealand, for community care in New Zealand. So there's a lot of challenges around different coding systems. I don't know if you've heard of any of them, SNOMED, ICD, NACNOC, lots of different things. Most of you won't know what I'm talking about, but there's lots of debate about what systems you use. This one works and it's been proven to work. So it basically goes from the concept of a problem. What is your problem? So rather than talking to patients about diagnosis, in those medicalised terms, it talks about problem. And then from the problem, we take a look at what is that person's knowledge, their behaviour, and their status of that problem. How well do they understand it? How compliant are they with the recommendations that we give them? And as a result of that, what is their status? Now, most of the medicalised environment focuses solely on status. This is about dealing with the social and behavioural determinants of health. We know from the work we've done over many years that capturing that has a significant impact on the quality of the outcome. So, as I say, this has been around for about 40 odd years. It's the taxonomy of choice for the Netherlands. So the Netherlands government have approved this as the way in which health services in the Netherlands will be funded. And numerous other countries around the world have picked this up for community services. So problem, knowledge, behaviour and status. From there you can determine what kinds of interventions you provide. So task-based, funded-based, what am I going to do for this person? But again, what it factors into it is not only treatment and procedures, but also what kind of education can we provide, what case management can we support, what kind of surveillance do we need to put in to address the knowledge and behavioural issues. Which is the outcome rating scale there. The other key thing, other than problem, intervention, and knowledge and behaviour and status, is it allows for what we call client-specific information, which is all of the other information that goes into constructing the story of this person. And that's particularly why I'm here, because some of the work that's been done with Lab Plus and the Service Innovation Lab is around looking at making available all of the services, all of the resources in the public domain that people are accessing or potentially accessing to support them living in their homes. And so this particular taxonomy has a framework to support that. So we can talk about things like what kind of assessment tools or eligibility rules apply, what kind of organisations are involved, what kinds of providers are involved, what kinds of qualifications they have to have, products, equipment, you name it. So this will allow for those things to go into this framework and say, for this person, this is the bill of materials, or this is the recipe that's going to keep them in their homes. This is a really rough, I won't spend too much on this, but I think the key point I'm trying to demonstrate, this is off AESOP page that we've got in our software, and the key point I'll make is that everything you see there is a lookup to a data table, and it's a table to a national standard or an international coding system or some reference source that's standardised. We're looking for a single source of truth. So the key thing about this is when we're putting together what is the problem for this person, what are we going to put in, how well do they understand what's going on, how compliant are they, and what are all the services and rules that are going in for this person's plan. Everything is linked up to a table. We don't have any free text of any kind. It's all just pulling from existing data sources. And this is an example of the kind of pathway or the kind of, at this widest level, what's possible. So this is really just talking about neuromusculoskeletal function. So it's something if you're looking to see an orthopaedic surgeon or you've got some problem with mobility, that's the kind of thing you'll be looking at. It describes as a pathway, okay, this is everything that's possible for that kind of a condition. If I'm in a health sector environment, what kinds of interventions would I do? And here's an example of all the different types of information or resources that I can apply to. Right. I'm not allowed to spend too much time. From there we can go from a pathway, the whole of the population options, through to what's planned for this person, down to what have I done today. So you go from something like 66 options, 42 are relevant for this person, and today I did 5 of those. Really quickly, in terms of data visualization, this is what you can get out of that Omaha system taxonomy. So here's an example of a number of nurses dealing with the same patient scenario. So same symptoms, same problems, but what it's demonstrating is different providers and different organisations are applying the recommended interventions differently. So I won't spend too much time, it gives you a demonstration. This one here is what we call the sunburst example, and what that's showing is that, again, mothers with mental health problems, and the different colours indicate how many problems they've got. The different rings indicate how many interventions we're doing for them, and the little bits of bling, what we call the bling on the edges, is how many signs and symptoms you're demonstrating. So we're able to look at, so immediately you can look at that and you're wanting to say lots and lots of colours and lots of bling means lots of problems and lots of actual signs and symptoms or evidence that they've got problems going on. So those are the people you'd want to target in terms of what you're putting into services. So we've done all that. What we've learned that in order to be able to deliver this kind of data, there's a significant burden of documentation on the providers to be able to capture it. We're using tablets in the field, it's considerable. Lots and lots of dispute and debate around language and terminology. We're mostly interested in capturing what we get paid for. Don't really focus too much on social behavioural determinants of health in terms of data collection. You know, we don't have any information around regional resources or what's available in my town, in my community, and very little engagement, despite our rhetoric around consumer engagement. But if you're on my side of it, where you're an advocate or a case manager or a care coordinator, what you find is people are more likely to engage if they're looking at their knowledge and behaviour. They will respond to different types of interventions such as teaching and guidance and education and coordination. And there's a massive scope to make available to them what are the resources available, what is my entitlement. So how do we match those two? The burden of documentation against what we want to make available to the consumers. We've taken ESOP, we've stripped it out, still remaining with the Omaha system architecture, and said let's build a consumer application. We're looking at engaging the individuals in self-directed documentation. So we've got the plans already, they're clinically valid, they've been proven, benchmarked, best practice. Let's engage the individuals in participating in that documentation, make them the owner of the information, use the pathways that are already defined as best practice nationally to drive the workflow in terms of what people can and can't document, and most importantly using a consumer-facing language. Really quickly, so we've gone from that really complex diagrams that I was showing you a moment ago in terms of the app to what it looks like now, in terms of just really simple, what's bothering me today, why am I worried about it? I won't bore you too much with that, but fundamentally same architecture but just much simpler app. It goes from like a 2-hour assessment to a 2-minute journaling. What we're going to do next, make it available to consumers and their advocates, make the navigational pathways that we have available direct to consumers. Obviously we stick with the Omaha system because it's a very generic, workable application in terms of language. We are currently preparing an R&D project around the best platform to do this, technological platform, and we are going to look at feasibility of blockchain as part of that exercise, the feasibility, I must repeat. And we're doing quite a bit of international benchmarking. We're part of an international community of practice. And you can see there, if you're interested in learning more about the Omaha system, there's a couple of websites there, and that'll give you a lot more insight into who and what we're working with. And there's our website and my email address, so feel free to give me a call or contact me. I'm happy to talk to you. Thank you.